All right. Well, thanks, Walt. Yeah, thank you all for having me. So I have some interest in airway and cardiac arrest. Hopefully, this talk is going to present some information that is interesting to you all. My goal is to be a little bit thought-provoking, maybe take some stuff home to your services, a good chance to reevaluate. Um, I'm assuming that most people are still thinking that intubation is kind of the primary or the go-to airway management strategy for cardiac arrest. That's certainly how I was taught. I remember being an intern and being told that no one dies without an ET tube in their mouth. Uh, and that's kind of, been my practice pattern. But there've been a bunch of really interesting studies and recommendations come out in the last couple of years that is calling that into question, especially in the pre-hospital setting. So I thought that's what we would talk about today to see should we still be intubating cardiac arrest patients or not. So no disclosures except as uh, Walt mentioned, I do hail from the Evil Empire in Louisville, part of the EMS group there. I work clinically at a community hospital. I'm also medical director for Fern Creek Fire and EMS, which is in the Louisville area, but no disclosures relevant to this talk. And here's our objectives, which just kind of laid out, review some of this recent literature and data on cardiac arrest airway management, and then understand some of the new guidelines and recommendations. So a big part of where I got the idea from this talk was just reviewing the 2022 airway compendium from NAEMSP. And it's a resource document of a 10 to 12, something like that, position statements, all to do with airway. Really, really interesting read. Would encourage everyone to take a look at those. They're all open access, but there is one specifically on cardiac arrest. And when I read it, I was a little bit surprised about some of the things they were saying that made me call into question the idea that, intubation should be our default airway management strategy. So let's take a look at the actual recommendations that they provide. This is just a summary. Like I said, the whole thing is open access, but this is a link specifically to the paper on cardiac arrest. And if you read through those, I want to call your attention to what it says here on the first one, and basically saying that all three BVM, supraglottic airways, and intubation can be considered as airway management strategies. And I thought that was a little bit interesting because, like I said, I had been trained that intubation was the default. So let's take a little deep dive into that. So, like I said, this has been considered the gold standard for many years, but recent studies have called this into question. And the reason I find it interesting is that, we know that there's a lot of challenges to intubating people in the field. So we have problems with, recognizing proper tube placement. Um, in-tidal has helped solve some of that, but it still happens. Tubes get dislodged more easily in the pre-hospital environment as, the patients are being moved and transported more than they would be in the hospital. Um, for cardiac arrest specifically, it is fairly challenging to intubate somebody while CPR is ongoing. So to have your best chance, a lot of times you have to pause in those compressions. Is that good for patient outcomes to have pause in the compressions to get an airway? Not sure. And then it's really difficult to maintain the skill set needed to intubate very successfully. So there was a 2005 study that showed a lot of paramedics are only getting one live intubation per year. Now, I'm not sure what services they were looking at. That certainly isn't true in the service that I'm medical director for. Most of the paramedics are getting much more than that. But the point is that if you're not able to intubate regularly, then that skill is going to degrade. So yet even in spite of this, we still default to to intubation as our primary. But what is some of this data showing? I'm going to start with this paper that came out in 2015, and this was a meta-analysis of some observational studies. And if you read the take-home point there, they say that intubation is associated with better outcomes. However, the authors noted that at that time, there were some ongoing RCTs that they said we really need to wait and see what these trials show because this is just observational data. So the first one that came out was in 2018. This was in JAMA, and it's called the Pragmatic Airway Resuscitation Trial, or PART. And it was 27 EMS agencies here in the US, and they were randomized to an initial airway strategy of laryngeal tube or intubation. And then they had a crossover to the alternate strategy at 3 and 5 month intervals. Just slightly over 3,000 patients. And they commented, I'm not as familiar with the laryngeal tube. Most of the, as I know around here, use iGel. They did comment that the laryngeal tube was used because it was the most commonly used supraglottic airway in the US. So no other supraglottic airways were allowed. That may limit the findings of this study to your specific service. But that's what they decided on. One interesting thing here you'll notice is that the primary outcome was 72-hour hospital survival. So one thing I do like about this trial was it focused on some patient-centered outcomes. I think often when we look at airway management research, we get really sucked into like first pass success, basically whether the tube went in the right place. And while that is certainly something good to look at, it's not necessarily a patient-centered outcome. What the patients care about is leaving the hospital alive with a good neurologic outcome. So what we really need to look at is if what we're doing is leading to that good patient-centered outcome or not. So I did like that they did this. And in their study, as you can see, the laryngeal tube had a small but statistically significant increase in 72. So that was the primary outcome. They did look at a few secondary outcomes that we often like to talk about. So ROSC, not exactly a patient-centered outcome. However, it is a prerequisite to get to the patient-centered outcome. So I do think it's something still important to look at. And in ROSC, better in the laryngeal tube group as well. And then we have survival to discharge, also better in the laryngeal tube group, and favorable neurologic outcome, better in the laryngeal tube group. So the authors of this study did have a few things that they wanted to talk about that are some confounders. So first of all, the time they noticed was 2.7 minutes shorter for airway placement in the laryngeal tube group than in the intubation group. That kind of makes sense. It's a lot quicker and easier to put in a supraglottic airway in most of the cases than it is to intubate somebody, which is one reason that, our crews have started to like those airways a lot better. But they said, maybe some of this was just the speed, we're getting that oxygen in quicker with the supraglottic airway. That could be the case. One other thing that was interesting is in this trial, their intubation success rate was like 51%, which is kind of low. And they didn't really go into why they thought that was, but it is something to think about, because I think we all would strive for an intubation success rate greater than 50%. So maybe if the success rate was higher in this study, would it have shown a different outcome? Not sure. One thing they did not assess for was if the presumed stoppage in compressions to actually intubate somebody versus, for supraglottic, you really don't have to do that, if that had any effect. on the outcomes. But another study came out that same year. This was actually published in the same JAMA article in 2018. So this was kind of a big article, I guess. And this is the Airways trial. It was conducted in England, which may limit some of the applicability to our system because I'm sure there's differences. However, they still use a paramedic-centric EMS model, so it is somewhat similar to the US. This one had just over 9,200 patients. And in this one, it was individual paramedics, not services that were randomized to different strategies. So paramedics were randomized to either use intubation or supraglottic airway as their initial management strategy. And in this study, they did use the i-gel, and they noted that was because it's the most commonly used supraglottic airway in England. So that's a point in its favor, in my opinion, for some applicability to at least the services around here. And in the primary outcome, they were looking at the modified Rankin scale to look for intact neurologic outcomes, either 30 days after, either at hospital discharge or 30 days after the arrest, whichever occurred sooner. And for those who aren't as familiar with the modified Rankin scale, a 0 to 3 is considered kind of good neurologic outcome. 4 to 6 is bad. So here's their data. And I think you can tell just by looking at the raw numbers, they did not see any statistically significant difference in favorable neurologic outcome between an intubation strategy versus a supraglottic airway strategy. And also, there wasn't really much difference in some of the other outcomes. One thing I liked about this is they looked at regurgitation and aspiration, which is something we hear as a point in favor of intubation, or people will bring that up, say it prevents these things. In their study, they didn't see a statistically significant difference in those things between intubation or supraglottic airway. The only thing they did see a difference on was ventilation within the first 2 attempts did favor supraglottic airway. All right. So just to kind of summarize that, this is a table from a 2019 study that then combined those 2 RCTs plus one that I didn't feel like we needed to talk about in detail, but did want to throw up there just for completeness, called the Cardiac Arrest Airway Management Study. And one thing, so those are what they're comparing. That one was in France, and it compared BVM versus intubation. One thing I didn't like about that one, or that limits its applicability to us, is that in the France and Belgium model, physicians and nurses are responding a lot in pre-hospital settings. So I think that limits some of its applicability. But otherwise, it kind of showed similar things here. It also showed no real difference between a BVM strategy versus intubation. So now we've got 3 RCTs all looking at slightly different things in slightly different ways, but none of which are showing intubation to be clearly superior. So taking this a step further, a systematic review in 2022 included all those studies plus a bunch of observational studies. In total, it included 99 studies covering over 600,000 patients. The authors did note for this that a lot of the evidence they considered like low to moderate quality because most of the studies were observational. There's still pretty limited RCTs. Again, I like the way that they laid this out because it's focused on patient-centered outcomes, not just whether we got the tube in the right place. And let's take a look at some of this. So for survival, and this was measured in 1 month post-incident or at hospital discharge, they did not see any difference across those 3 groups. In neurologic function, they were looking at either modified Rankin scale or cerebral performance category based on the studies. Um, so for BVM versus SGA, it seems to favor BVM. For BVM versus intubation, no difference. And for SGA, it depended on which one they measured. So for the modified Rankin scale, they did not see a difference. For the cerebral performance category, it did favor intubation. So mixed there. And then if we look at ROSC, these other things, no difference or favors supraglottic airway. First pass success favors supraglottic airway. Overall success, no difference. And then I did think it was important to note they were not seeing a big difference in any associated harms. So this was their overall takeaway from this systematic review, was that there is not really or limited evidence to suggest that there is a great difference in patient-centered outcomes between these three airway management strategies. So at this point, might be kind of scratching your head, like we've all been taught that intubation was the best thing. We know it has some drawbacks, some limitations, but still we felt like it was the best thing for the patient, which is why we've been pushing it so heavily. So how do we make sense of this data? Well, this is my takeaway, or this is what I think is going on. I think that this shows that the most important thing is that we are providing oxygenation and ventilation to the patient, and it does not particularly matter what type of plastic we use to accomplish that goal. When I talk about this with my paramedics, I say these are the tools that we have, and you need to pick the right tool for the job. But the important thing is that the job gets done quickly and efficiently, not so much what tool you use. And we know, that the brain and the heart are pretty sensitive to, low oxygen states. So the quicker we get oxygenation and ventilation, the more tissue we're going to save. And then that brings us to some actual guidelines then that we can apply to our services. So this is pretty recent. This is from 2023. And these are actual guidelines after review of the data that we can implement. So this is what they suggest. Either BVM or SGA alone can be used in cardiac arrest. BVM or intubation alone can be used in cardiac arrest. And then they go on to caveat down here. They say they favor your strategy should depend on the intubation success of your service. If you have a service that is intubating at a very high level, then maybe it makes sense to continue intubation. However, if your service is struggling to maintain high levels of intubation success, then it probably is a better strategy to go with supraglottic airways. And I did want to throw this up there. This isn't a PEDS talk, like Abby said. We're going to throw in our sprinkling of obligatory PEDS. But I did want to mention this because obviously, pediatric patients unfortunately have arrests as well. And the data is similar and actually in a lot of cases more robust for PEDS patients, I think, that intubation may not be the optimum primary strategy. I just wanted to throw that out there. All right, so is intubation dead in 2025? Well, I don't think so, but I do think that the data is showing that we need to be a little bit more thoughtful and that it may not be our just default, no thinking primary option like it has been in the past. And this is kind of my 2 cents. This is how I distill all this information. So my thought is that oxygenation and ventilation is the most important thing. And then I think if you, for whatever reason, don't want your service to continue intubating in cardiac arrest, I think the data that we're seeing in the recommendations support you making that decision and feeling like you're not harming patients. You're not, increasing negative outcomes for patients. And then the flip side of that is if you decide to continue using intubation as a, primary strategy for airway management, you have to make sure that you're doing it to a really high level. Like you have to devote the resources to doing it. That means frequent training, remediation for paramedics that their success rate falls below, a high cutoff. One thing that I hadn't mentioned before, but some of these studies were done before video was quite as available. 2018 wasn't that long ago, but my service only started getting video in, I think, 2020 or 2021. And I bet that's similar across the country. I think video has certainly increased our success rate. So, I think if you're going to continue to use intubation, you do have to put the resources into making it a highly successful procedure. And then another caveat to that is all of this data only is looking at intubation for cardiac arrest. It's not looking at intubation for other reasons, right? And we know that there are other reasons that patients need to be intubated. The problem is that the majority of paramedic intubation practice is during cardiac arrest. That's the most common thing that they will be intubating a patient for. So if you take away intubation in cardiac arrest, then you're going to significantly limit the amount of intubation reps on a live patient that they have. And then that may make them less likely to be successful in intubation for other reasons. So I think that it has to be a thoughtful decision with what you're doing. And then, just to throw it out there, I think the real reason that intubation will never die, it's supposed to land on my head, is that you just look too cool doing it. Okay. That was a joke, didn't land. Anyway. So if anyone is interested in learning more, this is a link to the Pre-Hospital Emergency Care podcast. This specifically links to episodes that they had on the airway compendium. So it will include their position paper on cardiac arrest, but it's a bunch more stuff that we didn't have time to cover. I actually would have liked to talk about several more things, but just didn't have the time. So I would really encourage everyone to listen to that. And then also couldn't stand up here without plugging the Kentucky State chapter of NAMSP. I think NAMSP is a pretty cool organization. If you're a member, you get access to the journal for free. And if you do decide to join, there's no additional fee for joining the Kentucky chapter. It's literally just clicking a box on your application or on your membership thing. We have 2 or so meetings a year, but it's just kind of a good group of EMS medical directors to bounce ideas off of and to have some more people to talk nerdy EMS stuff about.